You can start, Dr. Sujit.
Yes. Am I visible and audible, sir?
Yeah.
Yeah, good evening, everyone. Today we'll just go through a little basics of neonatal lung ultrasound. Right, we're starting with the basics of neonatal lung ultrasound. So is the time now, like initially during our bedside physical examination, we used to do inspection, palpation, percussion, auscultation, but now insonation has become the fifth pillar during our bedside physical examination. You all agree to this. And before starting with the lung ultrasound, we'll just go through a bit regarding the medias which are present during in our body, like the air, bone, fluid, and the soft tissues. So the air is known to be a bad conductor of ultrasonic waves, and whenever the beams reach air, all the waves are reflected back like a mirror. And the bone is known to be an enemy of lung ultrasound, and the bone absorbs the sounds, but it doesn't let the beams waves pass through it. And fluid loves ultrasonic waves, and the fluid lets all the beams pass easily. And more the softest tissue, more easily the waves are passed. So during a standard lung ultrasound examination, what happens in all the scannings when we do, the ultrasonic beams penetrate through the tissue, the fluid, whatever structures it hits, and the waves reflect back to the transducer. And what the when the signals reach, the machine will create an image of those signals which is it has received on the screen. And then our interpretation is actually the reconstruction of what the ultrasound beams have actually penetrated. But in lung ultrasound, it is a bit little different, that we actually analyze the artifacts. We are not seeing exactly the anatomical tissue which is present actually, like when you are scanning a heart or a kidney or liver, you actually see the shape of the kidney, you see the cortex, the medulla. But in lung ultrasound, it is not the same. It is actually when the ultrasonic beams reach or hit the air or the bone, it reflects back, and it actually creates some kind of lines which are known as artifacts. And the machine actually shows the patterns of those artifacts on the screen. And this could be some, and whenever there are any physiological changes or maybe pathological changes in the lung tissue or the pleural line, so these patterns of artifacts also change. And then these change in the artifacts we relate with the few pathological conditions in the lung. So first of all, why do we actually need to do lung ultrasound? Why not chest X-ray or CT scan, which we have been doing since so many years? It's known to us that chest X-ray CT is time consuming and needs transportation, and sensitivity and specificity is lower than lung ultrasound, and we are exposing our little neonates to the radiations. And initially what we thought that nothing else is available better, so let's continue with the X-ray and CT scan. But in next few slides, we'll go through like why ultrasound is actually better for the lung in our neonates. The indications of lung ultrasound are like it has diagnostic implications and therapeutic also. Like it helps us to differentiate from diagnose RDS and differentiate it from TTNB. We can diagnose pneumonias, pneumothorax, effusions, pleural effusions, lung edema, CLDs, and we can do lung scoring, and it will guide us whether we need to give surfactant in the babies, or if you actually need a repeat dose of surfactant. or whether your baby is ready for weaning from your respiratory support. It will help us to guide if there is lung edema, do we need diuretics, and it helps us to guide how is the response of the baby to our treatment. So what are the advantages of lung ultrasound over CT? It is that lung ultrasound is a dynamic technique and allows us for analysis of the lung movement in the real time. You can actually see what is happening at that moment in your lungs. It is a very quick process. It hardly takes 2 to 3 minutes to complete good comprehensive lung ultrasound. It's a bedside, no radiations. You can do it multiple times and without radiation. And the sensitivity specificity is high, and it also helps us to guide for the therapeutic procedures, your fluid management, lung recruitment. And the best advantage is that you yourself are doing, you're performing, and you know the clinical course of the baby, and you can correlate and interpret it in a better way. But only limitation is that it is operator dependent. You have to learn how to do it. The probe which we are using is a linear probe, which is high frequency, more than 9 megahertz, and these hockey stick probes are also available, which are good for extremely low birth weight babies with having high frequency and better resolutions. And while doing lung ultrasound, you need to keep your baby in a prone position, a supine. Yeah, supine is the best, but you can either do in prone and the left lateral positions, in the side positions. Your baby has to be quiet and calm. And there are two techniques to do. You can do either by 12 region technique or a 6 region techniques. So I'll tell you how you divide the regions to do the scanning. See, this is the anterior chest wall, this is lateral, and this is posterior. So your anterior region is divided into four areas. This is yeah, either left and right. So you put a line at the medial sternal edge, a vertical line, and a horizontal line at the fourth rib. So this is how you divide right and left areas, and again divide it into upper and lower. So right and left anterior, it is right anterior upper, right anterior lower, again left anterior upper, right, and left anterior lower. So these are the four regions anteriorly. Again laterally, you have upper and the lower region. One is anteriorly, you put a line at the anterior axillary line and one at the posterior axillary line, and horizontal line at the fourth rib, and again divide lateral area into upper and lower on both the sides, right and left. So these are anteriorly four regions, lateral four areas, and posteriorly the medial thoracic spine, a vertical line, and at the lower angle of the scapula, you put a horizontal line, and again divide it into right and posterior upper and lower, and left posterior upper and lower. So posteriorly four regions, anteriorly four, and laterally four. So these are 12 regions, and ideally you have to scan all the 12 regions every time. So just to be make it more easier, there is another technique which is called 6 region technique to scan, to just quickly do a lung ultrasound. So this would be left anterior, left lateral, and left posterior, and similarly 3 regions on the right side. So all the 3 regions are not divided into superior and inferior or upper or lower areas. Either anteriorly, lateral, posteriorly, only once you have to scan. So this way you can just do a quick lung ultrasound in the 6 regions. So routinely we do this, but when you think that there is severe pathology in your babies, and you can do a comprehensive 12 region technique also. So usually lung ultrasound is done in a 2D or a grayscale, commonly done like this. And MOD is also done to see a few of the moving interfaces. We'll go through in our next slides. So the position, how do we actually keep the position? I'll show you in the next slide. The depth should be 3 to 5 centimeters. And when you keep the probe, this is a probe Okay, kept exactly perpendicular to the chest wall, and this is a probe marker which is on the cranial side. So no tilting, no rotation, just horizontally. It is kept vertically, exactly perpendicular to the chest wall. No sweeping, no tilting of your probe. If you tilt your probe or you angulate, then you will get some different artifacts, and you might interpret a normal lung as abnormal. So the anatomy of our lungs are like, this is a skin, subcutaneous tissue, and then we have muscles. These are the ribs, and we have a pectoralis muscle and intercostal muscle. This is a pleural line, visceral and parietal pleura, and this is our lung parenchyma. This is how it looks in your lung ultrasound in 2D view. This is skin, subcutaneous tissue, pectoralis muscle. This black this is anechoic, is a rib. And in between the two, this kind of rib images, you will get the intercostal spaces. And this is a lung parenchyma, and this is how it looks in your lung ultrasound. Whenever you start doing a lung ultrasound, you have to start with a bat wing sign. Just concentrate on this bat wing picture. This is one rib, which is anechoic, and this is another rib, and this is a pleural line. So it is an imaginary look. It looks like a bat wing. So this is called bat wing sign, which you start reading your lung ultrasound with a bat wing sign. So just concentrate on this black area. This is called acoustic shadow. So when you do a scan, these are the ribs. These I showed you previously. These are black anechoic areas. These are ribs. This in between is a pleural line. This black area is below the ribs is called acoustic shadow. When your ultrasound beams hit the bone, as I told, this bone is a bad conductor, so there are no ultrasonic waves passing through it. And the area below that will be seen as a black area, which is called as acoustic shadow. This is also a normal, seen in a normal lung. So we have seen acoustic shadow, we have seen ribs, and this is pleural line. This white echogenic line is pleural line, and this is the acoustic shadow or the shadow bone. So the first sign which we need to recognize in a lung ultrasound is a bat wing sign. I told you in bat wing sign, you recognize the ribs, and this is a pleural line. This horizontal, echogenic, smooth, regular, hyperechogenic line, which is, then the thickness is less than 0.5 mm. This is called as pleural line. This is seen in a normal lung, this horizontal line. And it is 0.5 centimeter below the rib. This distance is 0.5 centimeters. How is it formed? This is an echo-reflection of the pleural lung surface interfaces. And this pleura moves with the respiration. And this movement is called as lung sliding. Lung sliding has to be present in a normal lung. So when the visceral and this is visceral and the parietal pleura, they are normally closely opposed, and there is very minimal fluid in between them. So when they move against each other with the respiration, this back and forward movement of the pleura is called as pleural sliding or lung sliding. And it looks like a shimmery line, an ant marching kind of movement. This is indicative of a normal lung. So whenever there is lung sliding, and with that A lines, I'll show you how A lines look. Then it means that this is one of the thing that the lung is normal. The seen in a normal lung. So I'll show you how the pleural sliding or lung sliding looks. See, these are the ribs. This is a pleural line. And this movement, I hope you can appreciate the movement of this line, shimmery movement of this line. And it is moving with the synchronizing with the respiration. This movement is called lung sliding or pleural sliding. So pleura is absent in certain conditions like in pneumothorax, in pleural effusions, in pneumonias, in ARDS, in pleurodesis, and pneumonectomy. Normally, we usually find this absent lung sliding in pneumothorax. We come across very oftenly in our practice. So this is one how an artifact is formed. See, this is a transducer. These are the electronic, these are the ultrasonic beams, ultrasonic waves which they come and they hit one of the structure. Let us imagine it hits the pleural line and there is movement of the pleural line. The pleural line moves. That is called reverberation. And when it moves, it forms some artifacts which are parallel to the movements shows some artifacts which are parallel to the pleural line. These are the lines which are equidistant from the pleural line and they are parallel. And these lines are called as A lines. These are formed due to the reverberation of the pleural line. So now let's see what A stands for, and A stands for air. A stands for A lines. So when there are good A line means there is good air in your lungs, and I'm happy when I see good A lines. So they are reverberation artifacts which are caused by the pleural line. They are echogenic, horizontal and parallel. I'll show you how. These are the A lines. This is a pleural line. These are the ribs. This is a pleural line. So these horizontal, echogenic, parallel lines which are present in the series parallel to the pleural line and equidistant from the pleural line. So these horizontal echogenic lines are called A lines. And A stands for air. It means when you have good A lines means you have good aeration of the lungs. They're hyperechoic parallel lines. You need to recognize these lines. These are ribs, these two. This is a pleural line. You can appreciate the pleural sliding also over here. This is A line. This is one A line. This is second A line. This is A line. This is A line. So you can appreciate it is equidistant from the pleural line. So these are A lines. I'm happy when I see pleural sliding, good pleural sliding, good pleural line. And when I see good A lines. Then we go to B. B stands for B lines and B lines are not very good. I feel B lines are bad. Not very happy when I see a lot of B lines. Show you how they look. See, these are B lines. They are vertical lines which start from, this is a pleural line. So these are the vertical laser-like hyperechoic, white. Hyperechoic means white lines, hyperechoic lines which are starting from the pleural line and they go down to the screen, to the bottom of the screen. And these are caused due to the ultrasonic waves encountering with the alveolar gas liquid interfaces. These are not seen in the normal children or in the adult lungs. These are only seen when there are some pathologics or sometimes they are seen in the normal newborns in the initial 48 hours after birth and they disappear as the baby grows, like maybe after 24 to 36 hours, the B lines start disappearing. So, and one more a thing you have to remember that these B lines, they synchronize with the lung sliding. When the lung pleura is sliding, the B lines also move with that. They synchronize with the respiratory movements. So if there are a lot of B lines, then they are seen in RDS, they are seen in pulmonary edemas, congestive heart failures, in pneumonias, in TTNBs, and when there is lung contusions. So these are how B lines look. So I'm not very happy when there are a lot of B lines. So again, there are severity of B lines. So they can be just B lines, can be confluent B lines or AIS. B lines, when they arise from and are roughly vertical, when they are more than there are 2 to 3 B lines, then then they are actually called as B lines. And 2 to 3 B lines in your one scan, in your one screen, so you call them as B lines, and they are significant. But when these B lines coalesce with each other and they involve the whole of the one intercostal space. This is one rib, this is a parenchyma, this is the intercostal space. है ना? So if the whole of one intercostal space is filled with the B lines, then they are called as confluent B lines. If they are well spaced, they are just significant simple B lines. When they are coalescing with each other, they are called as confluent B lines. When such pattern of confluent B lines are seen in more than 3 intercostal space, like 1, 2, and 3, and this is 4th. Here we can see in 4 intercostal spaces, there are confluent B lines. Then that is called as AIS pattern, alveolar interstitial syndrome pattern. So it means this is an initial, the few B lines, a lot of B lines, and more B lines. This is how the severity of B lines increases. So this is almost like AIS pattern, but you can still see the acoustic shadows in between. So it is called as AIS pattern. But when the acoustic shadows are also obliterated, then it is called as compact B lines, or you can also say as like it is a whiteout lung. So here you cannot appreciate the acoustic shadows. This is what we just discussed. This is how B lines are seen. These are ribs. This is acoustic shadow. These are B lines, which are starting from the pleural line going to the bottom of the screen. And there are many B lines which are there in one intercostal spaces, and B lines obliterate the A lines. You cannot appreciate the A lines here. So the B lines characteristic is that when they start from here and go to the bottom, and they obliterate the A lines. So this is more of like an AIS-like pattern. So another lines which we can see are C lines. C stands for comed lines. So these are comed lines. These are also look like B lines. They start from the pleural lines. They start from, but they do not reach the bottom of your screen. And they do not obliterate your A lines. See, in this picture, you can see the A lines. These comet tails are starting, but they do not reach the bottom of the screen. They just fade away. So such lines are called as comet tails. These are not of much significance, but you should know to differentiate comet tails from B lines. See, these are B lines which are starting and reaching the bottom, but these are comet tails which are not reaching to the bottom. So when you put a M mode, even in lung ultrasound, you do a M mode and you see a seashore pattern in M mode when you put. So see, this is the intercostal space. When you put a M mode line on this, you click the M mode button, you see this pattern. So this shiny dark echogenic line is a pleural line. So this pleural line is in between the superficial tissues and the lung tissue. So this is how you demarcate. The above area is the superficial tissues which has skin, muscle, and the subcutaneous tissue. And this is seen as beach. So the area below the pleural line, the lung tissue is seen as sandy patterns. You can appreciate some dots are there. This is full of dots. So this is sandy area and this is beach. So it is called sandy beach appearance or seashore appearance. This is like a sea and this dotted area is like a shore. So this is a normal pattern in a normal lung. So if you put a M mode and get this sandy beach appearance or seashore appearance, this is normal. So this sandy beach appearance disappears or changes when there is pneumothorax. So when you see this pattern of sandy beach appearance, means you don't have a pneumothorax in that particular zone. So let's see what happens to your lung ultrasound picture, how the artifacts change when you have RDS. So you start with the pleural line. The pleural line becomes abnormal. It is either obliterated or it disappears or it is irregular, it is thickened, it is blurred. So this is how pleural line looks, and the area below that shows consolidation. It has a bit of subpleural consolidation. In extensive cases of RDS, you have extensive consolidation also sometimes, and you have increased B lines. So depending on the number of B lines, pattern of B lines, you even score your RDS. You score and then you do a lung scoring, and then you plan for a surfactant in these babies. Sometimes you may have a bit of pleural effusion also. So show you how RDS. This is a pattern. How do you score? Score the lung ultrasound. So this is 0, 1, 2, 3. This is a Pratt score. And you have to do a scan 6 regions. You do not scan the posterior areas in Pratt scoring. You only scan anterior and the lateral areas. On both the sides, anteriorly upper, anteriorly lower, and lateral area. And these all the 6 regions, 3 on right and 3 on left, you score them from 0 to 3. And the total score will be 18. Show you. This is how you score the 6 regions. And this is 0, 1, 2, and 3. Show you. So when there are good A lines, then you score it as 0. When there are good A lines, there are no B lines, then you score it as 0. When there are B lines, presence of more than 3 well-spaced B lines, then it is, then you score it as 1. And when there are crowded B lines or confluent B lines, see this good A lines, you score it as 0. More than 3 well-spaced B lines, you score it as 1. And when you have this AIS-like pattern on confluent B lines, you score it as 2. In this area, you might or might not have subpleural consolidation. These dotted areas you can see below the pleura, these are called as consolidation. Then you score it as 2. When you have this whiteout lung or AIS pattern with extensive, these white dots, extensive subpleural consolidation, you score it as 3. So each region you will score and then you will add up all the 3 regions. So if your score is more than 8, then you plan for your surfactant. But yes, definitely you have to correlate the clinical condition. How is the FiO2 requirement? How is the lung scoring? And how is the respiratory pattern of the baby, and what is the FiO2 requirement? And how much ventilation you are already giving. So you have to correlate your clinical findings with your lung ultrasound pattern, and then you plan for a surfactant. In some extreme cases of RDS, you can have extensive consolidations, and you can even have hepatization of lungs. And the next, going to pneumonias. In pneumonias, you have extensive lung consolidations. You may have air bronchograms, fluid bronchograms. You can have shred sign also. And the pleural lines are also abnormal. Pleural lines might be irregular, disrupted, coarse. See, this pattern is very similar to your RDS. But in RDS, you have subpleural consolidation. In pneumonias, you have shred sign. I'll show you how the shred sign looks. See, this is a pleura. This is a shred sign. The shred sign, this looks very similar to the subpleural consolidation, but the margin is very irregular. See the margin, it is not very well demarcated. When you draw a line, it will be very irregular. So this kind of pattern is called as shred sign. And you even have to correlate the history of the patient. How is the sepsis screen? How are the blood cultures? How are the biochemistry? And then you can correlate and then decide. But the shred sign is definitely a pathognomic of pneumonias in your babies. So you have pleural abnormalities with the shred sign, and definitely more of B lines are seen in pneumonias. This is how here very clearly you can see the shred sign. And here again, A lines might be again obliterated. This is called shred sign, or also the fractal sign. So this is a video showing the shred sign in a baby with pneumonia. And these are the bronchograms. These white dots are air and fluid bronchograms. In some extreme cases of pneumonias, the area of lung might look like liver. This is called hepatization of lung. See this area, this is lung actually, but it is looking like a liver pattern. You can also diagnose pleural effusion in lung ultrasound, and it is much better than the sensitivity is much better than lung ultrasound than the X-ray. In chest X-ray, you need minimal 150 ml of fluid to be seen. But in lung ultrasound, even just a minimum of 5 ml of fluid can also be detected. So this is the advantage of lung ultrasound over chest X-ray. This is how it can be, the pleural effusion is seen, and then you can even measure the quantity of the volume of the pleural effusion. This is a liver, this is diaphragm, and this is a pleural effusion fluid. Lung ultrasound helps in diagnosing TTNB and also in differentiating TTNB from RDS. In TTNB, you can see a double lung point. What it means, the pathology in the TTNB is that there is fluid. So whenever there is fluid, it settles down. So the upper area is aerated. Aerated means there are more of A lines and no B lines. So this is the upper area of the lung, and this is the deeper area of the lung. So the lower region, in the lower region of your lung, you can see a lot of confluent B lines, means there is fluid. B means fluid is there, settled down. So this demarcation between the aerated and non-aerated lung is called a double lung point, and it is pathognomic of TTNB. And this you might ask, it looks very similar to RDS, but in RDS you will see subpleural consolidations. As I showed you previously, there will be some dots, bronchograms below the pleural line, but in TTNB you don't see subpleural consolidation. This is again one of the differentiating point from RDS. So in pneumothorax, you need to remember 3 points. The lung sliding is absent. How is the lung sliding formed? It is because of the pleura, the visceral and the parietal pleura slide over each other. When there is air in between, it prevents the sliding of visceral and the parietal pleura over each other. And that area where there is pneumothorax, the lung sliding will be abolished. And because there is so much of air, you will get more of A lines in pneumothorax. B lines will be absent. There will be no B lines, no comet tails in pneumothorax. There will be only A lines, and the lung sliding in that area will be abolished. And there will be a presence of lung point. Lung point is a demarcation between an area which has pneumothorax and an area which is normal. So one is the absent lung side, more of A lines, no B lines. So, and when you put an M mode, at that point, this is how your M mode is seen. This is normal, right? Seashore sign, this is sea and this is shore. Previously showed you, this is seen in this is how M mode shows us in a normal lung. But when there is a pneumothorax, this sandy pattern disappears and it is seen as a barcode appearance. We have a barcode appearance. This is called a stratosphere sign. or a barcode sign. This is a normal lung where you have sandy beach appearance. This is a pneumothorax lung where there is barcode sign. So this helps us to differentiate. If you are suspecting a pneumothorax, you put an M mode and you get a sandy beach appearance, then it means there is no pneumothorax in that area. This is a video showing absent lung sliding. There is absent lung sliding. There are no B lines, lung sliding is abolished, and there are A lines and no B lines. When you put a M mode on this, you get a barcode appearance. So this is a normal lung where you can see lung sliding, B line, few B lines, and there are A lines. In meconium aspiration, again the pleural line is obliterated and there is A lines are disappear. You will have more of AIS-like pattern and there will be subpleural consolidation. There will be few spared areas and definitely you will have some history of meconium aspiration. There might be severe atelectasis, pleural effusion also. So this is how a meconium aspiration pattern is seen. Here there is disrupted pleural line. There is subpleural consolidations you can appreciate here. There are a lot of B lines. There are air bronchograms and A lines are obliterated in this. So lung ultrasound also helps us to monitor the response to our medical treatment in BPD and also predict if in future your baby might develop BPD. So this is a study where at 7 days the lung scoring was done as I showed you previously. And if the scoring was at 7 days was more than 8, then this study predicted that the baby might have a different severity of BPDs. So our take-home message from this session, I just try to make it more concise so that because these might be for the initial phase. So there is a lot more to learning lung ultrasound. This is just for the beginners. And you need to remember that no artifact will give you the exact diagnosis and pathology or disease going on in the lung. It is actually important to incorporate your current complaints, your clinical pattern, your clinical condition, your signs and symptoms, your oxygen requirements, your medical history, and your physical examination, and then correlate your all these findings with your lung ultrasound findings, and then correlate them, and then come to a final diagnosis whether what pathological condition your baby must be having. So you should first ask yourself whether this severity of lung ultrasound actually correlate with your clinical findings. Sometimes your baby, a preterm baby might be well and must be very fine at 25, 28 FiO2 requirement, but your lung ultrasound might show you more of lung scoring. But if clinically you feel that your baby is doing fine, you can just increase your PEEP or your settings and then manage it without your surfactant also. Just don't depend on the lung ultrasound findings, correlate and you think what is the age of the baby, what is the clinical condition, what is the history, and then come to a diagnosis and then manage the baby accordingly. So, and then your final decision should be taken how you need to manage your babies. Yeah, thank you. I hope everyone is still awake.
Thank you, Dr. Sujit. It was really like to finish the normal views and pathology in 50 minutes. It was really great of you. Dr. Jamal wants to see, can you show the RDS features once more?
Yeah, sure.
Hello.
Yeah, I'm sure. Yeah, we can start with the pleural line. The pleural line in RDS is very irregular. It might be thickened. Its measurement might be more than 0.5 mm. And there might be subpleural consolidations also. So this is regarding the pleural line. And then there are a lot of B lines in RDS. I've shown you the severity of B lines. So you can score your lung ultrasound. Scoring can be done depending on the number of B lines and its density. And the A lines will be obliterated. So this is how it looks. So we score, RDS might show you different patterns. And you need to score depending upon the severity. It can be a mild RDS, it can be moderate, it can be severe RDS. So when you just have A lines, then you score it as 0. When there are more than 3 B lines in your spaces, so you score it as 1. And if they are AIS like pattern, lot of confluent B lines, like more than 3 intercostal spaces has confluent B lines, then you score it as 2. There might be even in your score 2, there might be a bit of subpleural consolidations, but when you have a whiteout lung or AIS pattern with extensive subpleural consolidations, then you score it as 3. Sometimes you might have pleural effusion also in your lung ultrasound in RDS. So this is how, these are the main features which you can see in RDS, in lung ultrasound. This is extensive subpleural consolidation. This is how it looks.
So in terms, people have been asking, there are a few questions regarding the pleural effusion.
Okay.
So what I would say is, pleural effusions and all those things are basically for the advanced workshop. In this, if you get see the basic features of the lung ultrasound, like A lines, B lines, recognize the lung sliding, and then even you recognize the B lines and the comet tail artifacts, that will be good enough. Because in POCUS workshop, basic workshop, these are our objectives. And if you tend to recognize this much, it will be good enough. So for the pneumonias, PTN, RDS scoring, pleural effusions, and all those, pathologies. So how to differentiate RDS and pneumonias? That is the question.
In pneumonia, as I showed you in my picture, I think there is shred sign. You won't see this kind of shred sign in your RDS. It has a different kind of picture, this kind of. This is the subpleural consolidation, how you see in RDS. And in pneumonias, you see this kind of shred sign. This could be one of the differentiating feature. And rest will be your clinical history and your biochemistry and your sepsis screen reports and all. Yeah.
So there is one question: what is the significance of C line? C line signify.
B lines shows that there is more fluid in your lungs.
No, C line.
See, C are comet tails. It it again signifies fluid only, but it can be a very minimal amount of fluid in your lung, which would be not of a significant amount. We just have to ignore such minimal amount of fluid. Yeah.
So basically, what she tried to show you that she just wanted to signify as ABC to make it easy, simplify that. The comet tail artifact is again nothing but showing the fluid, but lesser amount of fluid. If you have lesser amount of fluid, you get comet tail artifacts. If the fluid amount increases, then it becomes B line. And then those B lines, when they become more concentrated, that means there is a more fluid is like accumulation of more fluid within the lung parenchyma, and or there is some atelectasis that is going on. So then your B lines become more concentrated. So you have less than 3 B lines or 3 B lines in one section, in one sector, these are known as B lines. More than 3 B lines in one sector, confluent B lines. And then in 3 sectors, if you have confluent B lines, then it is AIS. And then if the differentiation of pleura with lung parenchyma and ribs, if it is gone, it is compact B lines. So this is how you say that signifies the amount of fluid has increased, or the consolidation, or the lungs have become, there is more congestion in the lungs. So that signifies that. So that's how she told A lines, B lines, and C, A, B, and C. C signifies the comet tail artifacts, and comet tail artifact is same as B lines, but that signifies lesser amount of fluid. So this is what she's been showing also in the screen. Okay, then there is a question regarding differentiation of RDS and meconium aspiration syndrome. I know these things would have been coming. I know our lectures, we stick to the basic, but it keeps on. So still have time, so you can just explain them. So that will be good for them.
Yeah, just come to that slide. Yeah. Just on the basis of pleural line abnormalities, you cannot differentiate. The pleural line abnormalities are seen in both, in RDS and in the meconium aspiration also. And there might be subpleural consolidation, but in meconium, there are spared areas. In RDS, there are no kind of there are no spared areas, but in meconium, there are spared areas. A few areas might have the shred sign kind of pattern. A few areas might look absolutely fine with just B lines. And definitely there will be history. Whenever you have MS baby, there will be a history, and there will be severe atelectasis in meconium aspiration babies. The pleura is disrupted, and there are spared areas. When you see the different regions, when you do a comprehensive scan, some areas might have this kind of pneumonia consolidation patterns, and some may have a severe form, and some might be spared. So this is how you can differentiate, and a history of meconium.
Yeah, so I think so. There are no more questions, and hopefully all the questions have been answered. Yes, I will share the PDF in the group after this lecture. So if there are no more questions, we can close the session.
Yeah.
So Dr. Rajesh, sir.